So can all of you hear me?
Yes.
Yes.
Okay, good. All right. Can I start now?
Yeah, we are live now. We can go ahead.
All right. Good afternoon, ladies and gentlemen. Welcome to the inaugural Asia Pacific Risk Association webinar. This is a series of regular webinars that we have planned, and we are kickstarting a new year, 2021, with this interesting webinar where we'll be discussing management of complex wrist injuries. This webinar will be divided into 2 one-hour sessions with a short break in between. And each 1 hour session will be led by 2 different sets of faculty and moderators, all hailing from the Asia Pacific region. So we are very fortunate to have eminent faculty members here among us who will be sharing some of the cases, and also to kickstart a very lively discussion that's about to happen on the cases that we are going to line up. For all the audience out there, whether you're on Zoom or OrthoTV, please do not hesitate to raise any queries or questions that you may have on the chat. Just type your questions, and hopefully we'll pick it up in the discussion that's about to happen on the cases that we are going to line up. For all the audience out there, whether you're on Zoom or OrthoTV, please do not hesitate to raise any queries or questions that you may have on the chat. Just type your questions, and hopefully we'll pick it up in the discussion that's about to happen on the cases that we are going to line up. For the audience out there, whether you're on Zoom or OrthoTV, please do not hesitate to raise. Right. Okay. So I'm not going to delay any further. I shall pass this session over to the first set of moderators, Professor Liu Bo and Dr. Jeff Acker. Over to you now, Liu Bo.
Okay, thank you, Andrew. We're glad to open the first session of our APWA first webinar. So the first session will include 5 cases in 1 hour. Jeff Acker and I will be the moderator, and we include faculty include PT Chen, PC Hall, Shining Chen, Yang Kwang Lee, Hoshi Nakamura, FJ, and also the faculty from session 2 is also will be asked for opinion as well. Okay, so shall we start the first case, which will be presented by Andrew Chin. So Andrew, please.
All right, thank you very much. Let me share the screen.
No. Okay.
Okay, good afternoon, ladies and gentlemen. I shall kickstart the webinar session with this rather challenging case that I managed not so long ago. All right, essentially it's a young gentleman who had no medical history of note, was involved in a road traffic accident, sustained a high velocity injury when he was flung out from a motorcycle for 1 to 2 meters right after colliding with the car, and he landed on the outstretched hand. Fortunately for him, he didn't lose consciousness. What he had was basically just a very isolated wrist injury with a 1 centimeter wound over the volar aspect of the wrist, as you can see from the photo on the right, with patchy sensory deficit over the median nerve distribution. And the range of motion was limited by pain, and there was a bit of swelling as well. So I would like someone to comment, be it a faculty or one of the Zoom participants, to describe the X-ray. Bolu, you have anyone in mind to describe the X-ray?
Yeah, start first. PT. Hello, can you hear?
Yes, we can hear you.
Yeah, so this gentleman had a right hand injury. I think the most striking features is a radial carpal joint dislocation with some flakes of bone torn off from the radius, especially on the dorsal side. And from the significant history of high energy injury and also the median nerve palsy, probably I think it's a emergency that we have to reduce the radius.
Yep. Sorry, I can't hear. Is there any?
I think Professor is muted. Can he unmute himself?
No. Yeah, okay. So I repeat that this is an emergency that we have to perform a reduction in the theater, and we align the radiocarpal joint and explore the median nerve at the first stage. So I will not perform any definitive fixation at the first stage.
Okay. Any other comments from faculty? Okay. If not, all right. So what was done for this patient was all right. He underwent a manipulation and reduction at the emergency department. All right. So is anyone suggesting something, because this patient after attempted reduction still having median nerve symptoms? Bolu, you have anyone in mind?
Yes, PT. What PT?
Yeah.
PT.
Yeah.
What will you do for this case with the patients still have median nerve symptoms?
Well, I have said I will perform the reduction in the theater, put in the X-fix and explore the median nerve. So just reduction in the ER is not enough. So do a external fixator, explore the median nerve in the theater as the first stage of treatment.
Okay. Thank you.
Yep. So okay, as what PT has suggested, okay, do we repeat manipulation? Yeah, maybe if you have time to, you can try. If you're waiting for the case to be sent to theater, would anyone actually offer a CT scan prior to even proceeding straight for surgery?
Yes, yes, I will. Yes.
All right.
Yes.
So instead of going straight to surgery, you'll do a CT scan first, right, before going to surgery?
Yes, this is PCO. I think I personally probably will do a CT if time's available and the patient's symptom is not so urgent. I think the CT will help. But of course, it all depends. For example, if this patient is admitted in the middle of the night, I think will be some sort of simple reductions, simple treatment will be better first to relieve the symptom and to reduce the dislocation. But say if this is patient is admitted early, we have sufficient expertise and operating facility, maybe you can actually plan for a little bit more treatment, even as for one first go. So CT scan will be helpful to examine better about the fracture fragments and also all the other details about the injury, so as to help us to plan the surgery ahead.
I support what PC said. I think that the important thing he said was if the symptoms are severe enough. So for me, if they've got a lot of pain and they're very dense numbness and they've got motor weakness, then we take it very seriously and treat the nerve. But otherwise, try and get the best outcome. So that would be if there's just numbness in the fingers, then make sure you do the CT and get the best surgeon to do the surgery.
Okay. So fortunately, this patient actually had a CT scan that was done. Okay, let me go through the CT scan with you in greater detail. It's in a, as you can see, there are fragments in the axial view. Right, and now I will go on to the sagittal view. You can see there's actually a radiocarpal dislocation, very obvious. The luna is actually dorsally dislocated. And of course, this coronal section, you can also see that the intraarticular involvement. Right. So we have the benefit of a CT scan prior to surgery, thankfully, because in our institution, we have a CT scan that's situated in the emergency department. So it's rather easy to wheel the patient into the room, get a quick scan done to help you to plan your surgery. Okay, so what was done subsequently for the patient? underwent a surgical exploration. We extended the volar aspect to look at the carpal tunnel and release it. And lo and behold, this median nerve is mightily swollen. All right, it's actually very, very swollen. So that explains the patient's symptoms. And we also had a look at the wrist capsule. It doesn't look that good because there's obviously lots of combination at the lunate facet. And you can see from here, and even the short radial lunate ligament was torn, and we had to repair it as well. Okay, so what was done for the patient? Extended open carpal tunnel release. We actually put on an external fixator to do a bit of distraction. We continue to fix the volar and the dorsal lunate fossa fragments and repair the torn volar extrinsic ligaments, mainly the short ligament. All right, this was an intraoperative radiology. And as you can see, it's not a perfect reduction because the volar lunate facet at some point in time is still not completely reduced despite doing the first surgery. So we decided that this patient will require probably another re-exploration down the road and perhaps a definitive fixation. Any comments from the faculty or the moderators?
Andrew, this PCO, may I ask why didn't you do the definitive fixation? Because since you already explored those fracture fragment and also the ligament injury, why not to do the fixation in one go?
Okay, good question. Because it was actually an open injury as well, and then we were thinking it's pretty swollen, so we are going to come back anyway once the median nerve swelling decreases, and then to probably have another relook. So we decided to actually not to disturb the thing at this point in time, just to do a. In fact, this operation was all done within an hour, so we decided to do it just in the middle of the night, stabilize everything, and then come back another day just to do fix it definitively.
Okay.
Andrew,
Okay.
this is Young.
Yep.
If I do this is Young. If I do the surgery, maybe I use the suture anchor to repair the ligament in the volar lips. Do you use any suturing?
Because the whole entire volar aspect is comminuted, so if I put a suture anchor there, it may not even hold.
Andrew, I'm Shanlin. What do you mean the severe swollen of the median nerve? It looks not so severe for me.
Is it? I thought it was twice the size. I will show you the post fixation, definitive fixation photo of the median nerve later for you to compare.
Okay, Andrew.
Yep.
Before you proceed, I'd like to ask our faculty if the patient is not so badly injured for soft tissue, what will be the definite treatment? Okay. So anyone has idea, suggestion for the definitive treatment for this kind of a fracture dislocation? Maybe Dr. Shanlin Chen.
This is really a tough case for me because we need to rule out whether the severe problem occurred in median nerve or not. I recommended using perhaps sonography to evaluate whether the median nerve was crushed or compressed, severe or not, and perhaps using an external fixator to reduce dislocation and fix the wrist joint temporarily. Perhaps several days later, I can perform the operation in only one stage to release the median nerve and reduce the dislocation further and fix the fracture. Yeah, that's my opinion.
Okay, any other opinion?
Maybe can I say something? I'm Jeffrey Koo from Hong Kong.
Yes, please.
Yes, in this case, I agree that the soft tissue is a big problem. So I agree that to start with, probably you can use external fixator to first reduce the dislocation and then temporarily stabilize with an external fixator, and then explore the median nerve with an open manner to see what happens to a median nerve. After that, if the swelling is improved, I I would use definitely fixation using a special plate that is a volar facet plate from Metis that they have a hook to hold the volar rim fragment. Usually in these situations, is the short radial lunate ligament is attached to the avulsed volar rim fragment, and this is this plate is helpful to hold the avulsed fragment in a better and in a very secure way to stabilize the wrist.
Okay, so Andrew, can you show us how you dealing this difficult situation in
sure.
the interest of time?
Okay, so actually the patient median nerve symptoms got better over the course of the next few days, and we decided to undergo a definitive fixation 3 days later. Okay, so this what it looks like just before the operation, the external fixator, and when we actually open up the dorsal, we actually look for the avulsed dorsal lunate facet fragment. And you can see here, we reduced it and we used the dorsal buttress plate from the Medartis. And the median nerve swelling actually decreased. You can see it's actually improved. And of course, it reflects from the clinical improvement from the patient as well. So just to recap this, how it looks like previously at the time of the first operation. All right, so what we did for the volar lunate fragment, as what Jeffrey Koo has alluded, we actually used the Medartis volar lunate facet plate, which is specially designed with a hook. And interestingly, we use this is a right-sided injury, but we use a left-sided plate for it. So because of the configuration of the plate, as you can see on the fluoroscopy later on. And of course, the DRUJ was unstable because there was a basal ulnar styloid fracture. We did a ballotment and it was actually unstable. So we decided to fix the ulnar styloid with a cannulated Halers compression screw. And so this is how this is how the fluoroscopy, let me play the fluoroscopy. So it was a very stable fixation, right? Both the radius as well as the ulnar styloid.
Okay, Andrew.
Okay,
thank you very much for.
Yeah, so this is how it looks like, and then patient actually recovered very well after 10 weeks of this.
Andrew, Jeff,
Yep.
sorry I joined late. Was the distal radial ulnar joint stable after you fixed the ulnar styloid? Because the ulnar
Yes,
styloid.
it was. We actually did a ballotment post fixation. It was stable. And in the interest of time, I shall play you the follow-up videos just to have a look at 6 weeks, where we actually started the patient on pronosupination after he was splintered for 6 weeks, and at 10 weeks where he actually almost recovered in terms of motion. But of course, the grip strength needs to be further improved with hand therapy on strengthening exercises. But otherwise, overall, he's actually quite happy. He's actually pain-free at this point in time. Yep. Okay, that's the end of my presentation.
Okay, thank you, Andrew. So Jeff, you will proceed to the second thesis?
Yeah, sure. Look, thanks, Andrew. The second case is going to be presented by Toshi Nakamura. So Toshi, feel free to start.
Yeah.
Andrew, while we're waiting for Toshi to launch, would you consider putting a Coelho splint on his forearm? Because he seems to be quite restricted in his pronation and supination.
Yeah, because I actually put it on a Munster splint for 6 weeks post fixation because of the unstable DRUJ. So allowing the fracture of the ulnar styloid to heal. And after that, I started.
Okay, we'll push on with Toshi now. Thanks, Andrew. I thought we'd fill the time in. Thank you. Toshi.
Yeah. Okay. No, it's not. I'm sorry about that.
I found a,
Find it. Do you find it?
Yeah.
yes,
Okay.
I think
sorry.
we're there, Toshi.
Yeah,
Well done.
I'm having a quick presentation on that. The patient is a 47 years old male. He suddenly felt difficulty to spinate when carrying a suitcase 3 months before his visit. Spination was blocked to 10 degrees while he can fully pronate. There's no DLJ instabilities and also the pain on the ulnar head. This is the preoperative pictures of the patient, so that the patient cannot spinate on the right wrist. Then that he can pronate, but a little bit restricted. A quick dash score was 32. X-ray shows almost normal, so there's no severe dislocation of the DIUJ or normal alignment or no fracture. Then arthrogram showing and some horizontal type tear and also the peripheral tear on the triangle fibrocartilage. But a CD shows some subluxation of the ulnar head dorsally. MRI looks normal. So in that situation, I have a question to you all. Then what is the diagnosis of the patient? First one is a pronation contracture. Second one is dorsal dislocation of the DIUJ. Ulnar upper abutment syndrome, but the X-ray doesn't show any positive ulnar variance risk. And then DIUJ locking.
Does anybody want to answer that question, or would you like me to direct it to somebody? Anybody there? Okay. Yong Kyun.
Yeah.
What would you do here?
I also diagnosed this case as DLJ rocking. I saw the very similar cases in the last 2 weeks, and I have a schedule. So I also diagnosed this case DLJ rocking. Because the dorsal dislocation of the DLJ and this is excluded by Frey radiographs and carpal abutment syndrome, the symptom is not the spination limitation is not a chip compliance. So this diagnosis can be ruled out. So I also think that the DLJ rocking is diagnosed.
Thank you.
All right.
Yeah.
So Jeff,
I actually showing that this arthrogram, then that you can see overlapping of the ulnar head to the TFC. So this is a typical sign for.
Can I raise some comment?
Mm-hmm.
Please, BC.
Yes, BC. Yeah, I think in the situation, because the patient has already has 3 months of history of presentation, so sometimes it's hard to differentiate whether it's a true mechanical locking or because of the patient excessive pain so much that it's actually lack of motion. And so that's resulting in actual contracture. So it's hard to differentiate. Somehow maybe you need some examination under anesthesia, either local anesthesia or general anesthesia, to be sure whether it's a mechanical locking or just what I call pseudo locking, if it's just due to the stiffness in capsule. Because somehow in that situation, a simple manipulation under anesthesia will work for the patient. But of course, if under anesthesia, if there is a true locking, I think we have to investigate. And still most likely because of his trauma, this is something related to TFCC, as you show in some of the arthrogram. There possibly some tear of the TFCC can causing jamming of the joint motion, and that actually produce mechanical locking.
That is true. That I agree with.
Another, as explained before, is that I actually has also another case as actually loose body inside the DRJ actually produce locking, and the loose body could be due to cartilage fragment. That is true. So that is another possibility.
Yeah, that sometimes the synovial chondromatosis on that inside the DAUJ that can lock the DAUJ as well. So can I move on?
PC, can I ask you, would you simply do an examination under anesthesia, or would you move straight on to arthroscopy at the same time in this case?
I still do similar thing. I would do some investigation first, since this is not an emergency thing. I think MRI would still be useful for me, or MRI program could another possibility to look at just to prepare the patient what we are going to do. And then ultimately, if the patient is in pain and it's a difficulty, I think still you need some surgery. But as what I say, I also has a experience of using just local anesthesia, putting around the wrist, and they actually can also solve some of the pain, which can produce limitation motion. But I think in general speaking, I think some general anesthesia probably will do better, so that the patient can completely relax and you can do a very good examination and manipulation and anesthesia.
So PC, you get an MRI and a full information base. You do an examination under anesthesia, and you do that under local anesthetic, or would you give them sedation?
I still think if the stiffness is significant, I do another general anesthesia or regional block,
right.
And then I
so
just proceed for an arthroscopy and then to evaluate the wrist joint and then treat accordingly.
Thank you. Toshi.
Okay, can I move on?
Yes, please.
Okay, second question is treatment. Also scope or open treatment or ulnar shortening. Those surgical options. And also that I think that we can add a manual reduction with a forced spination.
Right. Wing Lim, are you there? Is Wing Lim there?
Yes, yes.
Would you like to answer that one?
Yeah. I think I would still like to have MRI because or ultrasound imaging, because it seems that maybe some in the position, some software in the position jumping the reduction of the wrist, particularly in limiting the supination. So I think I will go on that directions if I cannot do a good examination on that.
Okay. PT, would you like to say what you would do, PT Chan?
Yeah, I think MRI will be helpful. So if possible, I will get an MRI before I go for a UA. Probably I will do it under general anesthesia and UA plus arthroscopy.
Would you do the arthroscopy after the EUA? Is that right?
Yeah. Yes. Yeah. MRI and then prepare for UA and arthroscopy.
Thank you. Toshi, you want to push on?
I did scope. I'm sorry for that video. This is the DIJ scope. So there is no tear on the triangle fibrocartilage from the 3-4 portal. It looks normal. Then this is the broad portion of the larger ulnar ligament that can prohibit spination. So that I put in a probe to raise the broad portion of the larger ulnar ligament up. Then ulnar head goes pulmonary to do a full spination. Then I debride those areas a little bit. Then I put a sugar sprint for 3 weeks in a maximum spinated position. After reduction, there's no instability DIJ, the patient showing a fully prone spination. That's my answer.
Toshi, can I ask you a question about the scope?
Yeah. Mm-hmm.
The scope is in the 3-4 portal.
No. That I actually checked the last night, and that is the DIJ scope.
Thank you, because I was trying to get orientated. I appreciate that. Yes.
Then we published a paper, 2 papers. One paper in a 2013 Journal of Wrist Surgery in a case report. Then the second one is a case series for the 24 cases in 2020 in the Journal of Surgery. The locking of the DIJ is indicating severe restriction of the spination, but free active pronation. Due to partial tear of the larger ulnar ligament or triangular fibrocartilage, so due to partial tear of the TFCC, locking due to a dorsal part, that can showing the severe restriction of spination. Then this case showing the palmar portion That is locked. That is the cause of the locking. Then that the final cause was TFC flap was going to the DIUJ. Then that can also show in a locking of the DIUJ.
Thank you, Toshi. That was a very interesting and
Jeff,
relatively.
I have a question to Toshi.
Yes.
You have to make it quick because we're just going over time. So yes, quickly.
Quickly.
Yeah. Yes.
Toshi, I saw your paper at the Journal of Hand Surgery European volume. In that paper, you described that any tear of the dorsal or palmar TFC was sutured if possible, but you only described in this case. So I ask you, in what case do you think TFC suture must be done?
That kind of suture in this one. This one can be repaired from the dorsal side, but this one cannot be repaired. I just resect palmar side. So dorsal portion can be sutured, or you can also debride this TFC flap, or you can suture. But I think the debridement is much easier.
All right, we'll have to push on to keep on time. Thank you for that question. It was very good. So, Bo, do you want to push on with the third case?
For the very interesting case. The next case is prepared by Professor Shanling Chen and will be presented by Dr. Zhixin Wang. So, Zhixin.
Yeah, can you hear me?
Yes, yes, please.
I will share my screen. Okay, can you see my screen? Okay.
Yes.
Okay, I'll start. Good afternoon, everyone. I'm Wang Zhixin from Beijing Jirishan Hospital. I will present this case on behalf of Professor Chen. So this is a 10-year-old boy, and he was treated by his classmate, and he didn't get any treatment. And when he presented, he has a painful wrist with excessive loss of movement. And from the clinical photo, we can notice that there is carpal volocygin and supination deformity. So I take a X-ray, and the plain film showed there is a minimal ulnar-styloid fracture, and the proximal row is inflection deformity, and the lateral view shows VC deformity. So can I ask if there is any opinion about the possible diagnosis and what you need for further diagnosis? Okay.
Yes, thank you, Zhixin. So I'd like to anyone as the audience like to answer the first question. What do you think the diagnosis of the case? It's not a very common case. May I maybe I ask Professor P.C. Ho? P.C., you need to unmute your mic, please.
Thank you. This is an extremely interesting case. Probably we rarely see. In fact, I would like to ask what's the mechanism of injury? Is the patient fall on extended outstretched hand or flexed outstretched hand? Is any idea about?
Yeah, actually, the patient is stepped by his classmate when he play around, falling around with his classmate. Yeah.
So we step on the hand and then
step on the hand. Yeah.
So that is probably some sort of downward pushing force onto the carpal bone, etc. Yeah. Because we actually see unusual scenario that is a volar subluxation of the capitae around the lunate, and also there's a severe VC deformity. And in fact, this X-ray, your view is not very clearly shown, but I have seen some of the bigger view in your previous information. Actually, there's some uncertainty. For example, we may see actually a bit widening of SL interval that we have to clarify whether there's any sort of SL dissociation. And also, there are also kind of the, on the outer aspect, the hemi and triquetrum is also overlapping. So we may have to certain where is the instability actually happen between the two carpal row or between the lunate and the triquetrum, because it looks like some sort of the a lesser arc injury, but in the different pathway. That means it could be, if there's a SL dissociation, we can start from the SL and then go through the capitulum, which is the weak point, the space of Poirier area. And that is as a hemitricutural subluxation. The force continues to go to the hemitricutural, and then finally probably stop at the outer styloid. So there's something quite similar to those more typical peroneal dislocation, but usually they happen in the dorsal side rather than in forward direction. So that's why this gives rise to a little bit an unusual scenario. And I think I would be interested to know whether the patient's any sort of a median nerve symptom, because in terms of the direction of the trauma. So is any kind of median nerve symptom or just besides pain and stiffness?
The patient just present with painful wrist without the nerve symptoms,
right,
and with movement restricted. Yeah.
Right. So I think basically I would say that definitely the patient will require treatment because of so limited motion and pain. I will try to see under general anesthesia. I will see whether the joint can be reducible because it's already 3 months. So there is this pessimism that it may not be easily reducible. If the alignment can still be reduced, I would like to do a fluoroscopy first to evaluate the status of all the ligament, those interosseous ligament as well as extrinsic ligament to understand the situation. It sounds like a palmar instability of the mid-carpal joints, essentially, but I would like to confirm whether the scapulae junction is normal or not, because otherwise the treatment may be different. And it all depends on whether the reduction can be done easily or because you can also do some arthroscopic release of those contracted structures, such as the volar aspect of the radiolunar joint, which is causing the volar tilt, extreme volar tilt, and you have to release of the volar structure, causing the volar subluxation of the capitate. And if that can be successful, then some sort of reduction and pinning can be possibly done at that juncture. Or if that cannot be done easily, then you may have to convert to open reduction and then try to stabilize the joint. Of course, with this age, we don't really want to do mid-carpal fusion because it's desirable. We still want to try to do soft tissue reconstruction. It's still correct.
Okay. Thank you, PC. So, Zhixing, would you like to share your investigations to the audience?
Yeah, it's just Professor Ho said we conduct a CT scan and we can see there's no apparent dissociation between the lunate and the triquetrum. And also we conduct a diagnostic wrist arthroscopy. And after anesthesia, we did some provocative tests and and under the fluoroscopy, we can see the deformity could be easily reducted. Yeah, and in the arthroscopy, there is no obvious dissociation between the scapholunate interval and the lunate triquetrum interval. So I think our diagnosis is palmar mid-carpal instability, same as Professor Ho said. And this is form of carpal instability, non-dissociative, with instability between the proximal and distal carpal rows. So how to manage this condition? And maybe there's some choices, and maybe professors can say about their opinions. Yeah.
I believe most of us we agree with Dr. PC Ho that in this situation, fusion is not a good choice. Probably most of us will proceed to some reconstructive procedures. So, Zhixing, in the interest of time, can you show us what will you do?
Okay, just like Professor Ho said. We choose a technique that promoted by Professor Ho in his paper, and we use the we reconstruct the dorsal radiocarpal ligament with a pisiform-based split of FCU grafts. And during the surgery, we stretch the tendon, and we can see the deformity of the carpal bones could be reduced and maintained, so that it confirmed the effectiveness of this technique. And we have follow-up at 18 months after the operation. And from the X-ray, we can see the flexion of the proximal row of carpal bones has been corrected. And on the lateral view, there is minimal residual VC deformity, but the general alignment is good. And most important, function recovery of the patient is good, and the patient has no pain, and the movement is generally restored. So this is just some summarize of this rare condition, the femoral mid-carpal instability. Yeah, if there's any, okay.
Okay, thank you. Any comments from the audience or the faculty?
I have one.
Two, yes, please.
Okay, actually, I've experienced quite similar case, but a little milder one, like a combined flexion of the all proximal row. And I've done the suture tape fixation alongside with the dorsal radial carpal ligament, put one anchor to the distal radius, another anchor to the trachytrum to tighten up. And got us quite similar results. So I think that might be an option for like a minimally approach. So, okay.
Greg Bain, the way I've managed this is to make a dorsal approach, and I agree it's the dorsal radiocarpal ligament's important. So I release that off the radius and I bring the whole thing down, a bit like a Blatt procedure, but so that it takes the dorsal capsule and makes it tighter. It's not a particularly difficult procedure to do, but my experience is it's often in patients who have some ligamentous laxity, so I may put some K wires across it as well to provide some stability.
Good point, thank you. So should we proceed to next case, Jeff?
PT Chan is going to present the next case. And this is a much more common problem and one that we all deal with. So we should get some considerable discussion from most members. So PT, please fire off.
So can you see the screen?
Yes.
Okay, so I'll start. So okay, sorry, I'll just go back. So here's a 53 years old dentist, and fell from bicycle is the left hand injury. For dentists, both hand is very important for them for their job. So this is the X-ray, and actually once he fall down, he just come to me. So the X-ray was taken about 1 hour after the injury. And of course, the CT is not done within an hour, but that is just to reveal the significance of the injury, the intraarticular stepping. And we also have the 3D reconstruction, but the 3D reconstruction didn't show the stepping quite well. But anyway, sorry. Okay, so what will you do?
Anybody want to answer that? Otherwise, I'll delegate it to somebody. Anybody feel free? Anybody like to comment on that? If not, I'll ask Toshi. What would you do with this, Toshi? Is Toshi there? All right. Well, maybe we'll pick Abby. Are you there, Abhijit?
Yes, I am. Yeah. Hi.
How would you tackle this?
Well, this is a very complex intraarticular fracture, and the treatment can be a pretty challenging one. And I think an arthroscopy assisted fixation would be of much benefit. One caveat that I would like to propose is to get traction views, or after you apply traction and then get the CT scan, because that kind of aligns the fragments better and changes the perspective a little bit. But an arthroscopy would be the way to go for me.
Okay.
I agree with that. Arthroscopy is very useful for the deduction and also diagnosis of the fragment displacement.
So how about after arthroscopy, will you use multiple screw or you still go for a plating?
That depends. Maybe that I try to use a plate for our looking plate. Then that within the KY years.
Okay. So I have a few questions.
May I add something?
Yeah, sure.
Because this case is a very common good cases. Usually, I would also like to take an X-ray on the contralateral side to see what is how the fragment is displaced, and the other thing is about the CT. CT usually don't use the 3D reconstructions because some of the fracture line will be cancelled out by the computer rendering. So because it affects the approach you would use to fix the fixations, either it is volar or dorsal. We need to try hard to see whether there is any fracture line over the volar side. If there is a fracture line over the volar side, then this case would be more benefit to approach it from volarly. And also agree that this case is a very good case, excellent case for the arthroscopy, because you can see that there is a central depressed fragment that it is much more easier for you to visualize under the arthroscope. Another thing is, mind you that because of intraarticular fractures of the distal radius usually associated with soft tissue injuries such as SL interosseous ligament tear and also TFCC tears. So arthroscopy adds another asset for us to assess these intraarticular soft tissue injuries.
Okay, so to go on for these two questions. So when will you do the operation and what type of traction will you use?
I usually do it about around 1 week.
Okay.
Let the
so
soft
around
tissue.
7 days, yes.
Yes, because to avoid any iatrogenic compartment syndrome when you use the arthroscopy. I know that someone would use a dry arthroscopy in these situations, but sometimes it's difficult, and sometimes you need to use the irrigations to help you to irrigate all the blood clots, and it will produce iatrogenic compartment syndrome.
Definitely. So in your setting, what type of traction are you using?
Hey, Toshi, please feel free.
Yeah, that's I used to use a dry wet scope in all surgeries, but recently I changed to the dry scope for distal radius fracture treatment, and that we can do it as early as possible.
I would like to say that I do these straight away. As soon as you get them, I do them dry. The sooner you get them, most of the time, if you put traction on them, they realign, and you have to do anything at all. If they're really impacted, you can elevate it. And there are some tricks that turn this into a simple procedure where you can use transverse subchondral wires and use the plate as an indirect mechanism, just turn it to a simple two-part fracture. But we'll keep on. PT, tell us in the interest of time, what did you do?
Yeah, I do arthroscopic assisted fixation. So the main problem, the main problem is this, actually the volar fragment is fractured and it is extended. Can you see the pointer here? So the problem is how to reduce this volar distal fragment because it's extended. You can see this part is actually impacted together with the central impaction.
Yes, I will use a suture to put the suture over the joint capsule, just distal to the fragment, and then try to pull it. Then you can reduce the fragment.
Yes, it's a good tricks to perform this. But anyway, another discussion, So my tricks is to just like others extraarticular fracture. I'll put the plate on it, but with a locking screw blocking on the proximal, so to contour this with the most distal fragment. And then perform an arthroscopy to elevate the central fragment so that the articular surface is smooth. And then put in K-wires. And then put in locking screw. And release this screw, then compress this. And because of the locking screw system, the whole volar fragment and also the central depression will check out. So this is my method of performing.
But how would you deal with the depressed the central fragment? Because by this your maneuver, because the central fragment is free, so it is difficult to move with your plate.
And once you put the volar plate, and then do the arthroscopy, elevate it and fix it with KY and then the screw first.
Okay.
That means you put all the locking screw to put the central fragment in place already. So
I think the most important thing is that we get an articular reduction and then we correct the anterior end plate. So PT, how do you make sure that you get the anterior end plate antiverted? Because one of the problems that I see a lot is that the reduction is with the anterior end plate neutral. So can we see what the reduction looks like?
Okay.
Oh no, press on. You keep going the way you're going. You're doing great here.
So
have you got a video with the reduction?
Just show you. Sorry, just show you the. So this is the reduction.
Sorry, can you just go back to that arthroscopic reduction? That looked very, very good.
But I'm sorry, this one is not from my own case. Actually, it's from Dr. Liu Bo. Another case is not exactly the same case.
That's all right. It still shows us the principles, and I think that's important.
Yes.
And
so
we just want to learn from this. It doesn't have the same case.
Yeah, this one is showing how to use a freer. So this is, you can see the use of a freer is one of the methods to elevate the fracture and feel for the fracture. So it's one of the usual tools. But another usual tool is to use the pop, because the pop has a advantage is it can elevate from the far side. That means you can hook on the far side to elevate the far edge, rather than use a freer from the near edge to elevate it. So both are very useful tools to elevate this central depressed fragment.
You can also pass a cannula or an obturator through the dorsal cortex and elevate it as well. So there's lots of different ways to do it. You can use wires, whatever you need. But that looks very good.
So sorry. So this is the end of this presentation.
Yes, but I would ask you a question. When you've arthroscopically reduced and fixed your radius, and you look around and you see there's a large peripheral tear of the triangular fibrocartilage, or there's a perilunate instability or a scapholunate instability, how do you deal with that? What are your options?
But this one I have scrubbed the mid-carpal joint as well, as it's only there's some bruising around the SL ligament. There's no definite instability, and I also screen it as in the dynamic screen. But if
PT, if you've looked across and you see there's a really big tear in your triangular fibrocartilage and it's floating around, and clinically you move the joint but it feels stable, what do? Do you fix the TFCC or do you just leave it alone?
For TFCC, I will perform a good reduction of the radius and then test the TFCC stability. If it's still unstable, probably I will put a spin first. I will not definitely, I will not go directly for a arthroscopic repair at the moment. I still believe there's some potential for healing. So
PC, I can see you're smiling. Have you got a comment?
No, sorry.
Joshi? No?
No, I welcome other comments because this is my approach. I think there is still some potential for healing. If after 6 weeks and go for rehabilitation, the patients still have symptoms, I will go for a repair at the second stage. So that means I will not overtreat those acute injury.
That was a very provocative question with no clear answer. But look, thank you, PT. That is a great case. It's something that we all deal with. We all deal with it a little bit differently. and that was very pleasant. So, Bo, do you want to press on with the next case?
Yes, yes. So a little bit late. We start late, so we still have a couple of minutes. So the next case, or the final case, presented by Dr. P.C. Ho. Dr. Ho.
Yeah, thank you very much. This case is just a recent case done by us, but it's interesting to share. He was a young gentleman's amateur basketball player, but a dominant right hand and forearm injury at a traffic accident because he was putting his hand outside the car, and then the car flipped over at about 80 kilometers per hour, and so it's severe injury in the right upper limb. So that's an injury. You can see there's a severe, terrible wound over the radial aspect and damaging the thumb and also the radial aspect of the wrist joints, the substance loss of some tendon, EPL, APL, EPB, and some muscle as well. And in looking at the X-ray, you see the actual complete loss of the trapezium. And also, although it sounds look like the first metacarpal base still there, but in fact, 2/3 of the radial aspect has been lost. It's only the remaining 1/3 of the outer side. So most of the articular surface is gone. And the trapezoid partial injury and also some loss of the scaphoid tubercle. Next, please. Okay. At the same time, he also concomitantly in the same limb, there also is a proximal montagial fracture dislocation. It's quite comminuted one, and also a distal radial sharp fracture. So actually, the surgery was done immediately the same night. Emergencies were performed, fixing the distal radius, and also quite a nice job by my colleagues fixing the ulnar and so on. And on the thumb aspect, they can't do much. So just using a KY to temporarily stabilizing the first metacarpal to the remaining carpal bone. So after a few debridement, actually the wounds looks better and clean. And as you see the extent of the skeletal damage here in the wrist joint. And here you can see that the problem is there's a large soft tissue defect with exposed bone and joint. You see the first MC was pretty floating around the area, multiple tendon substance loss, and also complete loss of the joint. And it was happened in a young active gentleman. So I would like to ask the opinion for the audience, what will you do?
Okay, thank you, PC. It's very really complicated cases. In the interest of time, I'd like to actually invite two of the from the faculty, maybe Professor Shanling Chen and our friend APJ. So we'll comment on what he do. So maybe Shanling first.
Because this is a case provided by PC, so I have to be very careful. Each time, case, very
a lot of pitfall maybe,
and with a very good result always. So for this patient, I think there are two kind of choices for treatment. The first one is to resolve the soft tissue defection first. So we can use some ALT or other site perforated flap, to resolve the skin and soft tissue defection. Of course, if I have the confidence for my debridement or some other else, we can do some reconstruction procedure in one stage with the perforated flap simultaneously, such as using bone graft or half FCR to reconstruct the connection between the base of the first metacarpal and the second metacarpal, and perform the tendon graft to repair the APL, EPB, or EPL. Yeah, that's my opinion.
Thank you. FJ?
Yeah, thank you. That's a very challenging case. So I agree with Shannon saying that we need to cover the soft tissue, and there are several options. One of the, the best way to deal with this is with the concept that came out of Louisville with emergency free flaps and tendon reconstructions at the same time. So if you are confident with your debridement and you have a nice soft tissue cover, you could do tendon reconstructions at the same time. And since the thumb is floating, I would think of, either using a mini tightrope at a later date, or maybe a tendon weave procedure to suspend the first ray for better function. Thank you.
Okay, thank you.
So,
Kisei, would you like to proceed?
Sure, sure. Yeah, I think in our we have considered whether we should what sort of reconstruction for the joint. I think for the soft tissue, no doubt we have to do some flap. But whether we should construct, so the consideration is either fusion or some of the soft tissue connection or using a mini type of. But we think that actually that because of the extensive bone and soft tissue injury, that sort of a solution may not give a very stable and mobile functional thumb for the patient for the high demand. So we're still thinking about some joint reconstruction option together with the flap reconstruction. So this end up into the final decision for making a double free flap reconstruction. And it was done in the Christmas Eve. We did till the midnight. It's a 14-hour operation. So what's the surgical plan? Basically, we would like to reconstruct the CMCJ with the metatarsal pharyngeal joint, the second metatarsal pharyngeal joint in a reverse manner, so that the proximal affects in the base and then the MC in the head. And then with the dorsal artery, we connected to a second flap. We choose the peroneal arterial flap from the same leg. And then using this, we connected two flaps in a series. We think the peroneal flap is reliable enough because it is there's a major arterial trunk that we can connect it with the dorsalis pedis. It will be more secure than the other type of perforator flap connections. And using this approach, we can possibly to bring the radial artery blood flow through the peroneal artery like a flow-through flap and then go to the toe eventually. So that's the design. We take actually we take the left leg, and we see the perforating coming. Finally, we can catch two major perforator, and the peroneal artery's dissection will be more difficult. So actually, we don't hesitate to orthotomize the fibula, so to turn the fibula outside so that we can actually see the peroneal artery very easily, and then we can complete the surgery. So that is the large amount of flap and also the trunk of the pedicle. You can see quite sizable pedicle. And then on the other hand, for the toe, we're taking the same foot, second toe. So this is the dissection of the MT head and the PP base. In order to create a good CMCJ, we have to do something before we can transfer. This is because of hyperextensibility of the MTPJ. So after we harvest the toe, we have to hyperextend until it cannot further extend. And then we stabilize at that hyperextended position, turn it around, and then the plan is actually fixed so that the metatarsal part will be fixing to the first MC base using a screw, and then the PP will be replacing using like a trapezium and then fixing to the trapezoid. And finally, in the metacarpal ligament, we actually using the deep in the metatarsal ligament to connect it to the second metacarpal to rebuild the soft tissue connection to the first MC. So with this plan in mind, that is the reconstruction. And we also do the tendon graft at one go using the plantaris tendon and also the palmaris tendon. And so this is a flap. I think the flap is very robust. We can actually see that this is the first flap. It's a very good blood flow before we connect it to the dorsalis pedis vessel. So that this makes sure that we can sleep well at the Christmas night. And we don't hesitate to make a little bit big loop because we think that this wide, gentle enough loop will not jeopardize the blood flow. So let me go for further. So this is the reconstruction. You see, I think it's quite nice looking. It's just reconstructing the first CMCJ and also the relationship between the first and the second, and also the other, the carpal bone. Further on. So for the foot, we don't want to create a foot defect. So basically, we're using some of the fibula and then harvest it and then put it interpose in the second MT area so to retain the length of the toe, because we don't want this toe to be too short and is ugly looking. And so that is the fibular graft that is interposed into the position. This is just in still early follow-up is around 18 days post-op. I think the flap goes well, no infections happens. And also the toes looks good and the skin graft is taken. And this is the latest X-ray. You can see that we recently has fixed most of the fracture well. I hope it's still going well. Maybe I can report the later functional outcome to all of you. Thank you very much.
Thank you, PC. Wonderful case. Any comments for this case?
No, I think it's very innovative and very, very creative.
Yes. So, okay. So, Jeff, would you like to close this session?
Well, I'm sorry I appeared late, but I'll finish. That was a fabulous session. Thank you to everybody that contributed, all those people that made comments. And I think we've got about 15 minutes left. Is that right? We've got a break for 15 minutes. Is that accurate? Before we
9
press on to
minutes.
the 5 minutes. Okay. All right. Well then, thank you to everybody. I look forward to seeing you in 5 minutes.
Okay, everybody, let's take a 5 minutes break. Refresh yourself, and the second session will begin at 3:15.
Thank you.
All right, thank you very much to the moderators and faculties of session 1. Well done.
Okay. According to my clock, it's the 1:15, which is what the time I think we were going to start. Andrew Chin, hopefully you can hear me as the co-chairman.
Yeah, I'm here. Great.
Would you like to present your case, share your screen, hopefully?
Okay.
Complex distal radius fracture. Thank you for joining us, everybody.
Can you see my slides?
Yes.
Okay. I don't know how. Okay, I'd like to start with this position. There is a 58-year-old heavy manual labor who suffered the right wrist pain, injured by fall from height. So this is what it looks like when he visited our clinic. So it seems, I like to describe a little bit. It seems like his right wrist was smashed with the distal radius was fractured with the multiple fragments, and they was involved in the volar dorsal sigmoid notch. And there is a strange cystic lesion on the triquetrum as well. Is there any comment on that? Shall I move?
Let's Wing Lim. Are you around, Wing Lim?
Yes, Andrew.
Yes.
Yes.
Would you like to comment on the fracture, and is it something you do? Yep.
Yeah. Can you enlarge the screen a little bit or use the presentation mode?
Julia,
yeah.
The slideshow mode or the presentation mode, yeah.
Okay. Oh, okay.
Yeah, great.
Thank you very much. Yeah, it's much clearer for me and for the audience now. So it's a very convoluted fracture, distal radius. You can see that both the radial column and central column are being involved, but there are quite a marginal and distal fractures with convolution and also marked angulations. I can see that there's a depressed fracture in the lunate, the fossa region, as well as the which also extend into the sigmoid notch, which is articulation with the ulna at the DRUJ. So I think that this is quite a significant injury that is going to affect both the radial carpal and the DRUJ function. So it has to be got into to manage both this articulation, the anatomical relationship is very important. One further very interesting thing that is that I found the shape of the ulnar head is a bit strange, and I'm not sure whether it's the density of the Xray or is there really a cystic lesion in the triquetrum?
I think so, and it's you'll see in a minute for the uninjured side. So I'd like to move on. So actually,
another question to Julia. I think this is a very interesting case because as you can see, I think do you have a previous X-ray, the normal PI? Yeah, you look at the lunate. It's a very, very funny shape. And it's very interesting because it does indicate that there could be some kind of I mean, the patient may have a query, maybe a pre-existing injury even before this fracture. That's something that we need to.
Yeah, but he denied any injury previously.
Also, Dr. Lee, do you have a contralateral side X-ray?
Next one.
Contralateral side, the other side.
Contralateral side. I prepared it at the last one, so so please wait. Okay. these are okay. These are oblique views. Yeah. Okay. The same. This is what it looks like in the CT scan. So it's a nasty fracture, multifragmentary, And my concern actually is that the sigmoid notch severely comminuted volarly, dorsally. So I just want to focus on restoring those sigmoid notch DLJ. And there is a sclerotic cyst, the sclerosis around the ulna and cystic region on the triquetrum. And this is uninjured side. Okay.
Okay, Jeff, do you have any comments? Jeffrey Koo.
Jeffrey, do you have any comments?
Yeah. So this one probably he does not have any injury on his now his injured hands. He has probably is a very severe ulnar infection syndrome that due to the very is an exceptionally long ulnar. Actually, the ulnar head is not articulate with the sigmoid notch. It is articulate with the ulnar side of the lunate. I think it is a congenital problem for him.
Yes, she doesn't complain any problems with the uninjured side. So so I would like to open this case to the discussion. So which method would you prefer? First, volar, or second, dorsal plating, or either combined technique or arthroscopic reduction plating, or any other methods? Andrew, can you progress?
Yeah, Margaret, would you like to offer your opinion for this?
Yes.
Yes. Yep. Yes. So thank you. I think this it looks like this is good. So with this case, I'm more worried. I'm also going to worry about soft tissue because it's a very comminuted this radius fracture. So for me, I need to look at the median nerve to make sure that there's no symptoms as well. And usually with these cases, I would do an external fixator and then to track it, but bear in mind that the other side, the ulnar is still positive. I'm not going to, so I know that I don't actually need to track it up to length to where the ulnar head is. So, and then I will likely to use arthroscopy to actually try to pin it, to try to reduce the fractures in a slightly better manner. And with that, so with the external fixator and some pinning, I try to reduce it as much as possible. And then I'll do a definitive fixation with volar plating later on in the stage when the swelling subsided.
Right. Jeff Ecker, would you have any comments on this?
Oh yeah, look, it's a fascinating case with pre-existing congenital anomaly and ulnar carpal impaction. And I guess the cyst is probably related to the ulnar carpal impaction and interosseous ganglion, but that'll take secondary precedence to fix it. I'd put that in traction. I'd arthroscopically reduce it. Then I'd put transverse subchondral wires probably immediately underneath the reduction to hold it. And then I'd use a volar plate with indirect plate reduction to reduce it. And if there's a significant amount of metaphyseal defect, I'd use some bone graft substitute. And then I get ready for the problems we're going to have with the distal radial joint and follow up the system, the triquetrum, to make sure it is simply an ulnar carpal interosseous ganglion, because you want to make sure about that.
Yep, certainly.
And I'd start therapy the next day. And I'd start therapy the next day, move the hand the next day.
Certainly, Juyap, this is a very interesting case because trying to fix a distal radius fracture in a congenital abnormally is no joke because the anatomy is so distorted. And to recognize the fact that the pentagonal lunate is actually not a type 2 lunate, but actually because it already has an inherent articulation of the ulnar head, so it makes it even more challenging. And,
I think you can simplify it by just dealing with the radius, Andrew.
Right.
And you need to check the carpet to make sure there's no scapholate instability, and just restore him back to his deformed self, and then deal with that.
Yeah.
Right. Okay. So, Juyap, would you like to tell us what did you do?
Okay. Actually, I didn't use arthroscope because I think it will take a very long time to fix from the volar. Actually, I planned to go from the volar approach and dorsal approach and fix it with like a sandwich plating. So I just went to the volar side first, and I tried to put them on. And I realized that the volar fragment was extended, extended rotation. Actually, it's exactly the same as PD Chen already presented the case. So I need to do something. So one option is to put this locking screw first and leverage it. So that's my preferred technique. And the second thing would be go from the dorsal again and try to reduce it and put some temporary K-wire fixation to reduce the volar fragment first to the volar plate. That's what I did. And put some distal locking screws first with the leverage technique. That means distal locking first and then the proximal screw later. And I intentionally put the screws a little bit shorter than this, than I'm used to, because I like to reduce the dorsal fragment later on. So if you see the fluoroscope on the right side, I try to reduce the dorsal fragment. Actually, that's the dorsal ulnar fragment, which is very important for the sigmoid notch. So I try to reduce it and fixed it with a very small locking plate, just putting on the intermediate column only. So this is what it looks like during the fluoroscope. And this is the intra-op, immediate post-op X-ray. It seems okay. And I think the distance between lunate and ulnar head is maintained like an uninjured side. But after, this is what it looks like after post-op CT. It seems like lunate facet is also reduced nicely, but I think what I liked about this is the sigmoid notch was restored and maintained with both plating. So, but unfortunately, at the last follow-up at POD 3 months, a little bit of a collapse is happening to the distal radius, and the patient is complaining about the ulnar side wrist pain later on. So I'm planning to remove the plate and shorten the ulna maybe several months later.
All right, thank you. KG, any comments from the fixation and as well as the treatment? KG Fujo, yep.
Can you hear?
Yep.
You did the bone graft enough volume, and this case is a very good reduction. But after that, a collapse occurred. So I would like to ask about enough bone graft.
Yes, actually, good point.
Important.
Good point,
right,
KG.
so
Actually,
I put some bone graft, right?
No, actually, I didn't. So that may be the reason of a little bit of a collapse. But normally, I am a strong believer that those metaphyseal commissions are healed very well, nicely with the mechanical support of the plate. So in my practice, normally I don't use bone grafts for most of the case.
Wendong, you have some comment, Wendong?
Yes. Yeah, UMP is very good surgery. And I think you just raised a question for the surgery. How about the ulna? So I want to know what's your opinion about the ulna. You just do the MRI and scope. You do the action. So So after, before surgery and during the surgery, do you concern about the iron head? What's your judgment?
So it's very difficult to hear from you, but in my understanding, you're talking about what would you do for this gentleman. So I think definitely I would do scope, but I might see some evidence of the ulnar infection, that's for sure. And interestingly, as all you can see, those intraosseous ganglion of the triquetrum was healed naturally. Yes, that is very interesting, because there might be an injury, trauma around the triquetrum, maybe triggers the healing. And for this case, I don't shorten the ulna very much. For most cases, maximum would be like 3 millimeters. I think that should be fine. The target point is not to make a zero variance, but to make quite similar to the uninjured side. So that is my intention.
Yes, Juyap, I agree with you on that, because the idea is not to normalize an already abnormal wrist to begin with. Because if you try to make it make the ulnar variance zero, actually it's going to be, you're going to distort anatomy of the patient who has already adapted for so many years to that anatomy.
Yes, I agree that if you restore it, there will be another problem that it will accelerate the DROJ osteoarthritis.
Yeah.
Right, Jeff, you have a comment? Jeff Ecker?
Yeah, Juyap, great work. The question I have is, when you do your shortening osteectomy and you take that abnormal ulna that's never really been articulating with a sigmoid fossa and it's painful, what will you do?
Yeah.
I think you're talking about some other salvage procedures, but I think he's happy with the previous condition, so
if he has pain, you said he's starting to get some pain on the ulnar side of the wrist, is that right?
Starting to have pain, yes. So
yeah. And you said that you would do a shortening osteectomy if you needed to, and given the fact nobody wants to do an ulnar shortening osteectomy in this man unless you have to, what would you do? You do your shortening osteectomy, and do you think you're likely to have pain? And if you have pain, what would you do?
I think you're talking about the pain comes from ulnar infection or DRG arthritis. Am I right? But I think this guy just were happy with the previous deformity. So, and I believe I restored my sigmoid notch very nicely after operation. So I still recommend him to do the shortened ulna. And if I choose the salvage procedure, such as salvo-Carpenti procedure, this will be disaster for this heavy manual labor for this young 58-year-old male.
Thank you.
Ju Young, that's been a fantastic presentation of a really quite a complex case. I think you've done it really well and taught us quite interesting things. Might ask now Wendong Zhu, new coming president next year, to provide his presentation on a complex intercarpal injury. Wendong, are you able to share your screen?
Yes, I'm ready. So first of all, I want to thank to Andrew who had made a lot of efforts in organizing such a great events. So the webinar's sign is management of complex wrist injuries. So I will bring this case to you. So this is a male, 24 years old, right wrist pain caused by for 1 week. So this is P right wrist swelling, motion limited, severe pain in motion. So first question, what's the diagnosis?
Wing Lim, do you want to comment on that? Wing-Lim, are you able to see that?
Sure. Yes. So thanks, Professor Xray, for your very exciting cases. So this gentleman is stating I think there is a obvious dorsal dislocation of the distal carpal road relative to the lunate, which is still sitting right in a topical position at with the lunate fossa on distal radius. So I can see there is a fracture of the scaphoid and also disruption of the complete disruption of the jugular line. So and also quick stepping of the lunate and the tracheum. So this is a transcaphoid perilunate fracture dislocation with a fracture of scaphoid and dissociation of the lunate capitate and lunate tracheal articulation. So it's a significant injury, and then have to examine carefully for any associated soft tissue injury, particularly any median nerve symptoms, and also possible any other compartment syndrome.
Well done. Wendong, do you want to continue?
Yes, very, very good. So the, the PA view of the wrist showed a fracture of the scaphoid waist. We could also find a small fracture at the space between lunate and the trapezium with set side. So the lateral view showed back dislocation of the capitate. So the diagnosis is trans-scaphoid perilunate dislocation. So then the treatment option. So this could be closed, reduction, open through volar insertion, dorsal or combined, or we use the arthroscope. So what's your choice?
So we were hoping to have the opportunity for everyone to be able to vote. I'm not sure that we can do that. Keji, what would you do with this particular case?
Yeah.
Keji, are you on there?
I prefer to use arthroscope, but in emergency case, resident or some emergency doctor will play a role of this operation. So open technique is easy to manage. First, under anesthesia, traction is very important. And this case is transscaphoid perilunate dislocation. So the scaphoid is necessary to deduct and fixate with double thread screw. And after that, checking the LT ligament or scapholunate ligament. And if there is some tone about LT, it's necessary to KYL fixation is necessary. Most of the cases, suture of the LT is not necessary. But sometimes scaphoid fracture is existed, so SL ligament injury is in their case, there is some tone of the scapholunate ligament. If there is SL ligament tear, I will play a role of suture with open technique. So I try to, I would like to treat with arthroscope, but almost hand surgeon, younger hand surgeon, I recommend to open technique. Okay.
Well, the younger hand surgeon, Bo Lu, how would you manage this, and what sort of challenges do you think you might have with that?
Yeah.
Bo?
Okay, thank you, Greg. So this is a very, yes, quite a challenging case. So we all have gone through the open procedures. We have a lot of debate on volar or dorsal or combined approach. But in recent years, personally, I will choose a arthroscopic approach. I always ask myself to if this in this situation, if the patient has contraindication for arthroscopy procedures. The main contraindication for me is the really chronic cases that I cannot achieve reduction arthroscopically. And the number two, the contradiction number two is the dislocation of the neonate is so severe, like all the way to the forearm. It's impossible for me to reduce the neonate back to the neonate fossa arthroscopically. So other than these two contraindications, I believe in most of cases nowadays, I would choose arthroscopy approach. Thank you.
So what challenge do you have doing it arthroscopically? What are the difficulties?
I think the key of the arthroscopic treatment for this condition is you need to achieve anatomical reduction of both the scaphoid fracture as well as the all the intercarpal intervals like LT interval. So we cannot compromise the anatomical reduction by mini-invasive, so-called mini-invasive approach. So I think this is the key to the most challenging part is you need to really reduce all these fracture and dislocation anatomically as possible.
Wendong, do you want to share with us how you manage this?
Okay, so just the further discussion we need to the reason because we cannot just reduct the couple, and whether there's a soft tissue and whether we should do the ping of the intercarpal joints. So let's see. So in the operation room, after anesthesia and the wrist traction, still we cannot reduce the carpals. So when we do the photos, we cannot find the scaphoid, tracheum, and the capitate. But lunate, we can find the scaphoid. We cannot find the lunate. So then we do the arthroscope. I agree, Fuji. This is the best choice. So with a 3-4 portal view, we can see lots of red synovia in radiocarpal space. Then we do the debridement via 1-2 portal. So here we can after debridement we find the distal part of the scaphoid shifted. It's shift to the dorsal part. We can see it. Then we move to the middle carpal. From MCR portal, the lunate cannot be found. We only find soft tissue in this position. Then we debridement all the synovium in the middle carpal. It takes really takes us lots of time. So after debridement, we found that the volar capsule was ruptured, whereas there are ligaments still continuously. It's good news. So then we moved to MCU portal. We did further debridement, the synovial middle carpal joint with a shaver from MCR portal. So then interestingly, we found this is the little scaphoid, capitate ligaments, and the soft tissue stunned fracture and block the reduction of the carpals. So with a view from MCU, we did complete lysis and exposure of the border side of the scaphoid and the lunate with a portal from the MCR portal. So after that, we can see the scaphoid and the lunate and did destruct the ligaments, and the carpals were successfully reduced. So after reduction of the carpals, we reassessment of the dislocation in metacarpal joint and find the lunate trochlear ligaments injuries. This is we find there's an injury in the lunate and the trochlear. So this is a caseless 3 grades at least. Then we use a screw, fix the scaphoid and the 2 KY to lunate trochlear joint. After that, we use the metacarpal view after fixation. We can find we successfully management of the trans-scaphoid peri-lunate dislocation. Okay, so this year is our program, and we hope in November we will successfully to host this workshop. It's international big events. Thank you.
Well done, Wendong. Very nice presentation.
Thank you.
And from Taiwan, would you like to make a comment on that? What do you think? Okay. EC Ho, would you like to make a comment about the management there? EC?
I think just well done. We all see very nice sequence, and also the logical thinking, and also I think the arthroscopy has a big role in transscaphoid perilunate fracture dislocation. Although in our early experience, there is a high conversion rate to open because of the difficulty in reducing scaphoid. The key is still is as long as you can obtain a good alignment of scaphoid, it's acceptable. If there's anything doubtful about the reduction of scaphoid, you may need to consider to convert to open. But in this case, obviously, it's a beautiful performance. So congratulations.
I have a question. To anyone. I just wonder the status of the dorsal intercarpal ligament, the connecting between scaphoid and triquetral. Is it remain still the normal or torn? I just wonder.
You mean the lunate and the trochlear, right?
Dorsal intercarpal ligament or dorsal scapulotrochanterial ligament, if you can say.
Dorsal part, actually, I don't think it's injured. We just found because the ligaments are stunned by the border part.
Okay.
We can see you just put inside in. That's intact. No
okay,
problem.
Preserved. Okay.
Yeah, preserved.
Yeah. When you do a volar perilunate dislocation, you'll often see the lunate sitting in the carpal tunnel, looking at you. And I often called it the pearl of the wrist. It's the distal articular surface. I wonder whether your case, basically that was still there, and whether there was a way to flip that capsule out of the way, like shoehorn it back into position. I just wonder what your thoughts are on that.
Yes, because this case is 10 days the history, so it's still a bit swelling, and so the carpal tunnel, we think about that, but after the traction we cannot find the lunate, and after we just put the scope to the radio couple through the 3-4 portal, and then when we finally find the lunate, so after that, I think that's do not worry about the lunate move to the carpal tunnel to the water side.
Okay. With such a big tear of the capsular structures, there's obviously going to be a lot more fluid going into the soft tissues. This is takes some time. Have you got any tricks to prevent carpal tunnel syndrome or compartment syndrome? Is there anything that you do to minimize the chance of those complications?
Yes, in my experience, my opinion is we had to just do the reduction within 2 weeks. If within 2 weeks, I do not think the lunate dislocation will cause the carpal tunnel syndrome.
Okay, but the swelling from the surgery, I meant from the arthroscopy. With all the big tearing of the ligaments, where all the fluid going into the soft tissues, is there anything that you do in this case to minimize those complications?
You just shorten your operation time, and you just because in Asia we usually use the wet scope, and in European some surgeons they suggest dry scope, so you just use the Swift. You have enough view to make those judgment. You just close the water, and I think it's a trick to just minimize your liquid input into the scope in the portal. You have to keep it in the mind. Because it's a very complex injury, and you may lead to the liquid to lead to a very very dangerous complication.
Right. Paul, you have any comment on that as well regarding the complications of carpal tunnel syndrome or compartment syndrome from prolonged wet arthroscopy?
Sorry, I missed you.
Sorry. Question to Bolu. Any experience or any comments regarding the prolonged arthroscopy and how to prevent the complication of carpal tunnel or compartment syndrome?
Yes, I'm very agree with Professor Wendong Xu that sometimes we can convert the wet. We can have a conversion between wet and dry arthroscopy. We have a lot of debate on dry is better or wet is better, but I think the current arthroscopists should know both wet and dry techniques, and you can convert freely whenever necessary. So I agree with Professor Wendong Xu that in this case you have a very long operating time. When you wash away all the debris, you can convert to dry to eliminate the chance of fluid drainage.
Yeah, thanks, Wendong. And
may I just make one comment here?
Yeah, go ahead.
Hello. Yeah, I think there's been always I would say rumor about compartment syndrome with wet arthroscopy. But I think it's mainly how you perform the wet arthroscopy. If I always insist that we don't use mechanical pump, we just instill the water at the height 1.5 meter, 3 liter saline bag. I would say that it's a very, very moderate pressure that actually produce quite minimal fluid retention. So using this technique, basically, is you can actually perform even some hours of surgery without compartment syndrome. So I think it's really the way that how you manage the fluid, rather than absolutely the wet arthroscopy will produce compartment syndrome.
All right, Ray Tian from Taiwan, you want to say anything because sometimes we couldn't hear you?
Yeah, do you hear me now?
Yep.
Okay, we have some technique for reduction the peroneal dislocation. We can use the small elevator from the dorsal portal and just take through the capitate at the lunate. That is easy to push the capitate back to the lunate fossa. I think it's a good idea to use the small elevator to reduction. And Wendong do the very well because you can resection all the synovial adhesion band here and more easy to reduction. I think the 1 week is useful. Copy the PC's idea and comment is just by gravity. Yeah, it's not easy to have the compartment syndrome or middle or carpal tunnel syndrome. If you pumping, yeah, it's easy to have the compartment syndrome. Is my idea. Thank you.
Good point. I think we'll go on to the next case. So I'll be presenting this case. It's a 31-year-old gentleman who had a motorbike accident, and he created what I sort of almost call as a burst injury to his wrist. And on examination, when he came in late in the evening, we noticed that his flexor retinaculum was ruptured. His median nerve and flexor tendons were on view. You can see the soft tissue injury there. We took him to the operating theatre that night. We did a series of fluoroscopic examinations. So the top one you can see is traction. The next one is radial deviation, and the next one is extension. We did an initial debridement. It was 1 o'clock in the morning when we did the debridement, and we just kept it as that, put a plaster slab on. The next morning we did a CT scan, and in our hospital we were able to offer hyperbaric oxygen, which we did. Because I just thought it may help with his soft tissues. We can see his CT scan there. We can see that it's a little bit of a jumble. And this gives us probably a better view with the static images of the CT. Jeff Ecker, would you like to comment on that? What do you think is going on here in this wrist?
Yeah, thank you. This is a severe high energy injury, which is predominantly soft tissue, joint and bone. It's everything. And the soft tissue is really quite complex. So it becomes a reactive process where you've just got to work out the best way to deal with it. And if you look at that X-ray, it's quite an emotional one. You can see that the scaphoid is gone. I don't know where it is, but it's gone. The capitate's flipped on itself. You're looking at the pole of the capitate. You've got a carpometacarpal dislocation of the middle ring fingers. Possibly the MC5's gone with a hamate, and the index finger metacarpal's gone with the trapezoid, and the trapezoid separated from the capitate, which is what you'd imagine because it's flipped on itself. The trapezium's fractured, the tubercle of the trapezium is gone, and to make things worse, he's got a complex sort of Rolando fracture. I think probably the only thing that is good about that is that the DAUJ looks quite reasonable, but it's complicated by high violence mid-shaft oblique fractured, comminuted radius and ulnar fracture. So at the end of the day, how would do you want me to keep going about how I deal with it, or would you want to give that question to someone? Sorry?
No, you want to keep going and outlining your plan, I think.
Right.
Very well, actually.
Use the debridement and get rid of all the damaged tissue, and that's going to be difficult because you're going to find it very hard to get to normal tissue there. You just probably take out the dirty stuff on the top. Fix the radius and the ulnar, and that's really important because you want to protect that distal radial ulnar joint. There's that distal radial ulnar joints you get out of jail free at the end of the day, and that mess, if it's intact, you've got to keep that together. So I fixed that with locking plates and screws. I realigned the carpus as best as I could. I mean, I don't quite know where that wrist is going to go, but your options are keeping the radiolunate joint by repairing the dorsal avulsion fractures on the radius so that you could get something like a four-corner fusion. If not, keeping the capitate in the right place, you could go to a proximal roquette pectomy if you had to. You want to realign and fix the carpal and metacarpal joints because they're going to be a headache, because if you end up with a total wrist fusion, you normally get some compensatory motion at the carpal and metacarpal joints, and if not, they're painful. I would actually put that all together, fix the dorsal ligaments, do the best I can with wires. If I couldn't hold it, I put an X-fix on it. If I couldn't hold that, I put a dorsal plate on it. And then I would not forget the base of the thumb injury, because at the end of the day, you know, the best result this guy's going to get is a jumping bit of bone that he can function with, or some sort of a salvage procedure like a proximal rocarpectomy or partial wrist fusion with a stable DRUJ and mid-carpal joint. The other end of the spectrum is he's going to end up with a total wrist fusion and a carpal metacarpal joint fusion. You're really going to want to have a decent DRUJ, and you're not going to want him to have a painful flail thumb. So paradoxically, I would fix the thumb arthroscopically. I don't like putting plates on him. He's had enough of an injury. You'd have to open it all up. You could do it that way if you wanted, and pin the reduced base of the thumb to the index finger and the carpus. But I would say that that's a really complex injury, and there's so many different ways of managing it. And they're my initial thoughts. And what I did would be dictated by what happened as it evolved, as I was fixing it, as I was working on it.
Yeah, I think that's right. Abaji, I think your clinic sees a lot of complex injuries as well. Abaji, how would you approach this sort of injury? Abaji? All right. Shiju Tim from Taiwan, what might you sort of know that you're in charge of a complex trauma unit there? How would you?
I said, I said main problem is the soft tissue. So initial the severe the soft tissue loss. For forearm, we will give the internal fixation to keep the alignment, and for carpal bone and the metacarpal bone, we will small K wire to fix and use the VAC to treatment the soft tissue. After 3-4 days, and we will do the debris again. If acceptable, we can give the early soft tissue reconstruction and plating for the radial and the ulnar. Yes, is my opinion. Yeah.
So our approach was the next day we took him back to the operating theatre, and we tried to fix all the skeleton that we could, and we might have put a vac dressing on it, but our plastic surgeons came in, I think the day later, did a little bit of a further debridement and put a flap on it. So this is where we were. So we debrided the volar wound. We made a dorsal approach, and we essentially looked at all this. Although you can see on the pre-op CT that the lunate did have, it wasn't completely stented. It had the short radiolunate ligament was actually at least stable enough to hold it there. We didn't do an arthroscopy on this joint. We were able to open this up and just put some small screws in it. And then we stabilized it all with K-wires. Now, I might point out I did this case over 10 years ago. These screws here, I think I'd probably use some form of headless compression screws now. But basically the aim was to just try and put it all together and do the best we could. And that really was an approach of, well, if we can do a limited wrist fusion, yes. The proximal rocarpectomy, I wasn't sure that was an option, but in fact, if the capitate was flipped around, maybe that was a possibility. And as I think Jeff pointed out, there's dislocations through the CMC joints. And so we basically reduced those and just held it with a transverse wire. So, and you can see the flap that's been put on there. I think that's actually worked pretty well. So 6 months, we took out the bridging plate. And interestingly, when we followed him up in the post-operative period, we could see that the ring finger had some malrotation. So although we thought we'd lined it all up, we hadn't actually got that exactly right. So we did an extraarticular osteotomy of the fourth metacarpal to bring that finger around, and that seemed to correct that. And then the articulation of the wrist, we can see we've got modest motion and strength there, but he was able to get back to his work and be able to do most things. So Wendong, any comments about that? Is Wendong still there? Wendong's there. Maybe PC Ho, do you want to comment on that?
Yeah, well, I think I will do probably similarly. I think the internal bridging plate is a good idea because actually it makes the whole things less complex. Because if the alternative of external fixator, probably the patient comfort will be compromised. And I think the goal is really to create a four-corner fusion style of a stable mid-carpal joint and then maintain the articulation at the radial lunate interval. So in fact, the key point is how well is the articulation between the lunate fossa and the lunate, which you can be realized at the time of initial surgery. Because that will be a problem if that is also traumatized, and then you will have to go to the fusion option. But I think I still agree that this sort of initial management rather than the primary fusion will give a chance the patient has some functional motion at the radiocarpal joint, because we can always turn to a complete wrist fusion whenever necessary if the stability of those carpal bone and the carpal metacarpal joint is not stable enough. We can still offer this option. Yeah. Otherwise, I think it's well done. Thank you very much.
It was interesting with the workup of this case. I had in my head the algorithm was that we try and do the limited wrist fusion, but we may need to do a full wrist fusion. And all of the other doctors that were with me just said you have to do a full wrist fusion.
So actually, may I know this, the condition of the joint between lunate and the radius? Is this still good when you assess the joint?
So at this point in time here, this articulation actually looked pretty good. And one of the things that's nice about the bridging plate, we just made sure that this was lined up. An important teaching point is when you put a bridging plate on, you need to be careful that the bridging plate doesn't subluxate the joint, because it can do that. But we're able to line that up, and I was quite pleased with that. And certainly from a functional point of view, he's been able to get back to active work, which was important to him.
May I ask just one follow-up question, Greg? Do you, when you put the bridging plate, do you deliberately distract a little bit, or you keep it in an anatomical position for the joint?
Yeah, no, that's a good question. So I actually think you're best to slightly distract it. And the reason for that is that if you put a bit of distraction on it, you leave a joint space between the radius and the lunate. And so as a consequence of that, it means that the soft tissues, when the bridging plate comes off, they're already a little bit loose. I don't think you want to do a big distraction like we used to years ago with the external fixateurs. I think it's just a subtle distraction. Any other comments from the team? I have a couple of concluding slides I just want to put together. One of the questions is, what sort of injury is this? And Mark Garcia Elias put together this classification back in 1989, so it predates most of us. But what was interesting, I've thought for some time that the real issue here is that this is a distal carpal row instability. I'm not sure he said it quite like that. I know he pointed out some of the interesting points of how you get the different radial and ulnar-sided instabilities. And so we can get an appreciation of that, but all of them involve the distal carpal row. And so although it's called an axial instability, I don't think that's quite the right term. It should either be a longitudinal instability because it's along its entire length, or it could be called a sagittal instability, but all of the distal carpal row. But of course it extends into the carpal metacarpal joint as well, and in some cases to the proximal carpal row. We published this some years ago about these transverse injuries. So you've got the greater and lesser arc injuries, which I think everyone in our group is familiar with. And then there's the translunate arc, which are these complex carpal injuries, which we've a few cases of those. And what's important about those is we need to stabilize the lunate first if we're going to do that. But all of these are really transverse instabilities that involve the proximal carpal row. So the way that we're trying to look at this and trying to get an understanding of how it all fits together for these complex injuries is these longitudinal instabilities usually go up to the carpal metacarpal through the proximal carpal row and may come out somewhere here, and they can be radial and ulnar. So these all involve the distal carpal row, and these all involve the proximal carpal row. And that really covers pretty well all of them, with the exception of these two. The Barton's fracture, everyone in our group is familiar with that. And this is the coronal fracture of the lunate with a mid-carpal instability. These are quite uncommon, but something that we found with our complex intralunate arc injuries. So what we propose is there's 3 fundamental types of complex injuries in the wrist. But of course, all the cases presented tonight, including this last one, they have components of all of them incorporated, so there can be some volar, sagittal and coronal involvement, all of those. So I think I'd just like to finish on that as a concept of how we can look at the different sorts of carpal instabilities in our clinical practice. Okay, thank you. So I might take any questions, and then I think we hand over to Andrew as our chairman.
Yeah, it is a very interesting case. I'm sure any other faculties would like to comment, or any other words of wisdom. Margaret, do you have any input regarding this case? You got to unmute, Margaret.
Yeah. No, it's great. No.
Okay. Jeff, yep, I saw your hand.
I just want to reiterate, I think when Greg said he was facing this terrible injury when he was relatively young and he had all these peer group telling him to fuse it, it's amazing what the body can do if you give it a run, and good judgment, Greg, hanging out there, because a lot of our peer group would say, just fuse it.
Thank you. Yep.
Greg, looking on the hindsight, would we have done anything differently after experiencing so many years of pain and inputs?
Yes, so the first thing is I would have used the headless compression screws, I think. And I would have made sure that the carpal metacarpal joint was better reduced, because that 4th finger was a bit malrotated. I almost feel like that's what I'd call a rookie injury, sort of a complication that an experienced surgeon really shouldn't have. But otherwise, I was pretty pleased with it. The other point I'd like to make is the importance of we do the debridement on the first day. We try and do all the reconstructive surgery the second time, and ideally have the plastic surgeons put the flap on. I think if you're leaving it for more than a few days and doing vac dressings and things, I think you're actually doing the patient a major disservice. So I think it's really key to get your flap on within that first few days and not delay it.
Agree.
Okay. So I might wrap up the session if I could. The first thing I'd like to say is that I've been really impressed with all of the presentations today. I think it fulfills the dreams that we all have for APWA, and some of the dreams that PC Ho set up some years ago, that we exchange information, that we join together. I think this has been a great session. I think the idea of trying to keep it to 2 hours is the right way to do it. I saw at the AGM there was discussion of doing this every 6 months. I think our group has enough energy that we can run it every 2 or 3 months, or certainly more often, particularly if we keep it short and punchy. Andrew, I'd like to thank you for all your hard work. Margaret, for the forum that you're putting together, which is a really valuable thing. And Margaret, you might choose to take the cases we've presented here and put them up. So you've got then 7 or 8 cases straight away for discussion. So thank you. And Ju Yup Lee and Toshi for their leadership in the society. We thank you for continuing to do that and all the hard work. So Andrew, thank you very much for everything. I hand over to you to close the session.
Thank you.
All right. Thank you very much. I would like to thank, first of all, I think most important, the leadership of APWA, who has endorsed and supported this initiative, and giving me the opportunity to actually kickstart this webinar series. A lot of you have given me your great support. It has made my life so much easier. And I will certainly want this thing to continue, right? We have so many people in APWA, so many talents who are able to continue this this whole amazing webinar series. And of course, I wish also to collaborate with other organizations such as IWAS, in ASSH, or even other societies that may have interest to propagate this. So it gives me great pleasure now to actually close this session. And please look out for future webinar series, be it 3 months, 4 months, 5 months, or whatever. We'll make it happen. And certainly this is by no means the last of it. And please continue to support APWA, and your presence here today has been really felt and appreciated. So from the bottom of my heart, and also on behalf of the APWA committees, thank you very much, and I hope to see you again.
For those of you who are listening that are not members or financial members, we very much look forward to having you being an active financial member in our society, because there are some costs to generate these sessions. Those of you who aren't active members, we would encourage you to join. Andrew, thanks again.
Yeah. Just a word announcement, the faculty members and moderators, please stay back behind for a short session of debrief. Yeah, thanks. Bye for now to the rest of the participants and supporters.
Yeah, yeah. Oh, and for those who really want to have further discussion, you can join APWA and then go and then log into the forum later to have further discussion about the cases.
Well done, Margaret.
Photo time now?
Yes, of course.
So